Assalamu alaikum, the communication day. We have Mrs. Julia Alfred. She's 21 years. You are the doctor in the medical OPD. She gave history of recent thyroidectomy for the medullary thyroid carcinoma. She was tested for MEN2A gene, which came positive. This disease is autosomal dominant, and the chance of developing phagocytoma is 50%, and the hyperparathyroid is 10%. As the disease complications. No family history of cancer, and she is planning to marry soon. All what is needed is to do annual follow-up by serum calcium, catecholamines, and calcitonin. If she wants to be pregnant in the future, we need to do prophylactic thyroidectomy for her child before the age of 5 years. If genetic test came as positive, your task is to explain the disease, counsel about the genetic and family planning, address other concerns. So we can start in seconds. You ready?
Yes.
I will remind you in 2 minutes left.
Okay.
Yeah, here you go.
Okay. Hello. My name is Dr. Mahmoud, one of the doctor here in the outpatient clinic. Is this Mrs. Julia Alfred?
Yes, I am.
And your age is 21 years old, right?
Yeah, doctor.
Okay. So I'm here today to discuss about your health condition, answer your question, and address your concerns. But at the beginning, I just want to ask you, how much do you know about your condition, and to be on the same page and help you to address all your concerns.
Yeah, doctor. Actually, I had some lumps in my neck for the last 3 months when I feel some abnormal sensation in the neck, and it was like lumps. When I went to my GP and he referred me to some doctor, the surgeon, and they did some of blood tests and hormonal tests, and they told me there is cancer in this gland in front of my neck, and they did for me a surgery to remove this cancer.
Yes, I'm really sorry about what you've gone through. And did anyone explain for you what is the cause of this cancer, or what you have a condition?
No, doctor. I came today. They told me that I should do some genetic testing, and I guess the result released soon. So
Yes.
I came here to hear about it.
Yes, I have the result with me now. But let me explain for you what this test was be done for, and what is the result of this test. Okay.
Okay.
So you are right that you told me that they did for you a removal of the gland in front of your neck because you had a cancer in this gland. Where they send you for this genetic testing to confirm a diagnosis of a condition called MEN syndrome. Had you heard about this condition?
Never, doctor.
MEN syndrome, I will explain it for you now. It means multiple endocrine neoplasia. It means that it is a condition that affects many organs in the body, including the thyroid gland, which is the gland in front of your neck. That's why they did for you this surgery. And also, it could cause also to develop some a tumor in the gland on the top of your kidney by 50%.
What do you mean by tumor, doctor?
It's one of it mean as a gross, can cause a gross on the gland on the top of your kidney, but this gross, it could be benign, it could be not cancerous, it could be a normal gross, it could be not be cancer, but it could be in some cases cancer. That's why this is the things. And also it can increase also in the gland. There is also 4 gland in your neck, can cause also increase in this gland that secretes the calcium, which is salt in your blood. So the condition, I think that I'm telling you a lot of information, but let me summarize it quickly. This condition affects many glands in the body and can cause some of the growth or cancer in such glands. Are you following me till now?
Yeah, doctor. Yes.
Yes. Okay. So what we will do, that's why we will do for you a follow up every year by checking the secretions or the hormonal secretions by each gland to check if there are any growth or any growth in the other gland in order to intervene. Okay.
Okay, doctor.
And I just want also to tell you that this condition also is an inherited condition. It means that it can affect 50% of the offspring. Okay. So
Yeah.
yes, do you have any brother or sisters?
Yes, doctor. I have two sisters and one brother.
So I highly advise you also that they can also can do screening for this gene because they might have this gene.
Okay, doctor. But they never have something like me.
Yes, I really appreciate that, but some people may not have symptoms, and this gene, and some people may present it late, so they might only to screen for the test in order because there's some precautions and some tests that treatments that we can give if we have this gene positive. How does that sound?
Yeah, doctor. Okay, I can call them to visit you and your clinic.
Okay, that's great. And Mrs. Julia, I just want to ask you, do you plan for? Do you have children?
Not yet, doctor. Actually, we are planning for marriage soon. Me
Yeah.
and my boyfriend.
So that's great. I'm happy for that. So that's good that you
Thank you.
that and you share this with me. So I think in the future, when you be pregnant, we need also to follow you closely. And also when you have your kids, as I told you, it might affect 50% of the offspring. So we need to do for them this to screen for this faulty gene. And if your child carry this faulty gene, unfortunately, we need to do for him the same operation that we did for you in order to prevent cancer from developing. How does that sound?
Yeah, doctor. But you will do it while they are kids.
Usually, we are doing it before the age of 5 in order to prevent cancer from
Okay, doctor.
from developing. And the other thing also, I just want to tell you about your condition, that we will follow you regularly and we'll give you also some replacement proteins because the gland in front of your neck is secreting some protein. So we'll give you replacement for this protein and
Mhm.
we'll close following you, as I told you, by annual follow-up to check if you have any growth or any symptoms of other gland in your body. How does that sound?
Yeah, doctor. It seems great, doctor. But how I can feel any change of these glands? Can
Yes.
you? Yeah.
So when you, as I told you, there is three parts of the body can be affected, which is the gland in front of the neck. With this, we have removed, so you won't have any symptoms, and we'll give you replacement therapy for that. And the gland, there is two gland on the top of your kidneys. This when this gland secrete more proteins in the blood, which is called catecholamine. These proteins can cause increase in blood pressure. So we'll monitor your blood pressure. It can cause for you feeling headache, heart racing, sweating. So if you have all any of these symptoms, you can let us know or let your GP know. And also the other gland, as I told you, the four gland in your neck also, it can increase the salt in your blood, call it calcium. So you might feel thirsty, you might feel you need to drink too much water and you go to the loo frequently. You might have some tummy pain and you might have also low mood or sometimes can cause for people confusion. So this is alarming signs that you feel it. If you feel have these symptoms at any time, you can go to the GP. But for us, we'll follow you regularly every year to check for this hormone, this protein secreted from this gland, from both glands.
Two, 2 minutes left. Okay, doctor. Yeah, great, doctor. Thank you for your advice.
Okay, and I just want to ask you some question regarding your lifestyle.
Yeah,
Do you smoke?
yeah, doctor. I smoke 5 cigarettes per day for the last 2 years.
So I highly advise you to stop smoking, because smoking also can cause cancer and can affect your health. So I can refer you to the smoking cessation clinic, if it's okay with you.
Okay. Yeah, it sounds good, doctor.
And what about alcohol? Do you drink?
Yeah, doctor, socially at the weekend.
Okay. And I just want to also ask you, do you have any question for me?
Actually, doctor, you give me a lot of information. However, I digest most of them, and I can understand that I will have follow up in the future with you and in your clinic.
Yes.
Yeah, I don't have any more doctor question.
Okay. And I know that I give you a lot of information today, so I'll give you some leaflet, and also I will give you the phone number of the nurse team,
Mhm.
specialized nurse. So at any time you have any questions that run in your mind, you can call her directly, and she'll give you all the answer to your question, or she can contact me, and then I will contact you later. How does that sound?
Yeah, doctor, thank you for that.
Okay.
Sounds very good for me.
Okay. Thank you. Okay.
Okay, doctor. Anything else you want to give to me?
No, I will give you now some leaflet, and I will send for you a text message with some sites that you can read more about the Men's syndrome and how to and the genetic testing. And also, if you want, I can ask the genetic counselor to have a sit with you and to explain for you more about this condition.
Perfect. Time's up.
Okay.
Yeah, I guess no comment, Dr. Sarah. Really, you did it perfectly.
But I can see that the scenario already, it's written all the information in it.
Whatever, you have to deliver it in non-medical way.
Yeah.
Okay. And the only thing you were about to miss is,
Counseling.
yeah, the red flags or the counseling or safety netting. How
Yes.
I can know that the disease is already manifested.
Yes. Yes.
So you have to give these things before you ask for the social work or the social history or before the 2 minutes left. But anyway, you did it. I asked you, but
Yes, you asked.
next time, do it by yourself.
Yes. Yes.
Any counseling for any disease, put before the concern, put alarm or put a circle in your paper, red flags or alarming sign or whatever you are naming it. Name it whatever you want to name, but remember it. You have to give some instruction about the disease, the red flags, how safety netting, something might happen and I need to review the doctor for that. You should do this for any condition, either counseling or in the medication, for example, prescribe medication and the patient doesn't know more about the condition. He doesn't know about the medication side effects. So you have to give some instruction at the end. Please, whenever you feel this, let us know. Visit us, call us, or whatever you want to say. The only thing also you missed the job. You can ask the job only, and if you are supported, everything is okay. Yes, doctor. And also you add something which is not written in the scenario. And this is for the clinical judgment, by the way. How do you know the thyroid is not functioning or dysfunctioning now or become hypothyroid state?
Because there's
Sometimes,
for
yeah,
her thyroidectomy, so we need to have a replacement.
sometimes they are doing partial thyroidectomy. It's not
Yeah,
total.
but it's not
So,
written.
so yeah, you don't know.
Yes, so you're right.
Yeah, maybe they will judge like you added something which is not correct or it's misjudged by you. So the best way is to say we will follow up your hormone level of this gland, and in case it's decreasing or declining, we can add some of the replacement to help you to cope with the condition. Okay, but it's not necessary to have full thyroidectomy or total thyroidectomy as you are saying, as they are the surgeons saying. Okay.
Yes, yes. Okay.
Mm. Okay. Any question, Dr. Sarah? For
I
me,
just this is
you
right
covered.
in the scenario. It's right that we do genetic testing and do prophylactic thyroidectomy before the age of 5, because the first time I know this.
Yeah. Yeah. It's doing like that. They are doing like that. Before the age of 5, it's like prophylactic. Before it will be malignant one or cancerous one. And as I stopped you tumor. You said tumor. Don't say tumor at all. Or you can say tumor and explain it. The tumor means overgrowth of the gland, either good or bad. Okay, some candidates saying nested growth or whatever, but it's overgrowth. Okay.
Overgrowth.
Yeah, and the possibility of being a cancer,
10%.
10%, or in the pheochromocytoma, 50%. Regarding the thyroid nodule, it's the medullary carcinoma, it's 100%. That's why they are advising to do thyroidectomy for most of the patient. Okay,
Okay.
but the point of replacement according to the part removed.
Yes. Okay, I won't say that.
Yeah, don't say something which is not written. Unless it's written, you have to prescribe for her thyroid replacement, so you can advise and tell her about this. But if not, you cannot say it.
Okay.
Okay, well done, Dr. Sarah. Please write your scenario until we can have a discussion from others.
I write this now.
Yes, I can see. Look, your scenario in which category, Dr. Bas? The scenario I wrote, it's counseling and genetic counseling as well. As Dr. Sarah said, I try to link between the last 3 sessions of communication, which is genetic counseling. We did a scenario for Huntington, and the main aim in Huntington, discourage for the genetic counseling, as we summarized yesterday. The HOCM counseling, and the main aim also here in the HOCM is to do or to encourage for it. Today we discussed the MEN 2A, and in this scenario, strongly advise and encourage to do testing. Why? Because there is possibility 100% to have medullary carcinoma in every patient, plus the autosomal dominant inheritance of the disease. So 50% of each child will have the condition. You can add also, Dr. Sarah, that we can counsel the genetic team, or we can refer you to the genetic team to have a safe babies. Or if she has a baby already, we can do the thyroidectomy.
Okay.
But yeah, she should be referred to the genetic counseling team. Okay. You got it, Dr. Samah? So we have now three scenarios for genetic testing, and according to the type of disease, either to encourage or discourage to do screening or not. Any question from others? Any discussion, any inquiry, please feel free to discuss and to comment. Okay, understand it. Thank you, Dr. Samah. Doctor, is thyroid cancer? I think in thyroid cancer, I think they must do total thyroidectomy, no partial, especially in men. Okay, good to know. Anyway, if not written, don't assume it. If they wrote it as a replacement, so you can do it. If they write in the scenario, patient had total thyroidectomy and she should start on hormonal replacement, so you can do it. In the previous scenario, it's not written. That's why we can't assume it's total or partial or whatever the type. Anyway, just stick to the task and the scenario. What they wrote, explain it. If she asked you, for example, let's assume that she didn't say it, and I am the one asked it. Doctor, please, will you give me some replacement or some hormones because of the gland removed? If I ask this question, Dr. Sarah, suppose she can say what she answered, since it's not written as a detail.
So
However, yes.
can you say it again, the question?
Okay, again, if you didn't raise it by yourself, I will give you hormonal replacement for the glands removed from the front of your neck. If you didn't say that, but I asked you from my side, doctor, will you give me
I will tell her,
hormone.
I will return back to the note to know exactly what type of
Excellent.
surgery has been done for you. If it's total, the whole gland is removed, so you should
Yeah.
have a replacement. If a part of the gland, well, I think we do further testing to check that the other part are functioning, and according to that.
Yes, perfect. So sometimes it will be considered as clinical judgment, and the most safe way to answer is to refer the patient to the concerned team. You are here, the medical OPD doctor. You are not the endocrinologist. You are not the surgeon. You don't know. However, if you can tell, according also to your answer, be diplomatic. We will review your blood test or your hormonal levels, and according to the level, we might give or not any answer, but don't be strict answer like, yeah, suppose, or we must give you hormones. Who told you? It's not written in the scenario. So please, either to be safe, to refer to the assigned team or the surgeon or the endocrinologist or gland doctor. They will decide for it, or to be in the neutral between give or not to give. How? By saying, we are not sure about the condition of your gland now. If the hormone being low, we might give you a replacement. If not, so we can do without giving this medication or the replacement. Any answer is accepted, but don't stick to one answer which is not written in the scenario. It might be against you in the clinical judgment. However, if the total thyroidectomy written as total thyroidectomy, here it's not written, so I cannot say this is total thyroidectomy. Recent thyroidectomy, we don't know what the type of thyroidectomy. The take-home message, don't add something which is not written from your side. Don't be volunteer to say that. If the candidate asks you that time, you have to answer, and he will judge you in this answer. Okay, I will explain to you, and I will give you example. In exam, I had the ICH scenario, okay, and the patient cannot swallow, of course, because he's in coma. One of the question was, doctor, will you give him feeding, or will you feed him? So they deduct mark from those candidates who answer yes, he can take NGT feeding, and that the task was end of life care. Okay, so they deduct as clinical judgment the candidate who said yes, we will give him NGT feeding, and anyone said food by a spoon, any type of feeding, they deducted them. The only answer for this was IV fluid, because this is end of life care, and we all of us know, whatever the patient in the end of life care, you can't give him feeding. Okay, so the answer here is no, we can't feed him. He cannot swallow. Even we are not thinking about NGT feeding because he is dying. How you feed patient is dying. Okay, so the best way, and this is clinical judgment again, they want to hear from you that you will not feed him, only IV fluid. And we mentioned this in the topic of end of life care. Any scenario with end of life care, don't give feeding, only IV fluid. Okay, the comment for all candidates, give the patient NGT feeding, and they minus them in the clinical judgment. Okay, I said IV fluid and they didn't minus me in the clinical judgment. It's clear now. Some information you have to know, and it will be clear. And others according to the scenario, but don't be the volunteer to say it. Let's go back to the end of life care again scenario. Did I say from my side, we will not give him feeding? No, she asked me particularly, doctor, will you give him feeding? And that time you have to answer. But if not, don't open it. End of life care means your father is dying, and it's a matter of hours or minutes, and we keep him comfort, try to keep his dignity and so on. But don't raise the issue and details of the issue unless it's asked by them. If she asked or he asked you, you can answer. But you know the answer. No feeding in the end of life care. But the palliative care, you can give whatever you want. Okay? The same here. If the replacement not written, don't offer it. Do what is written for you. So instead of saying I will give hormone replacement or whatever, no, I will give you some education about the manifestation of the disease. Increase thirsty or feeling thirsty. Increase frequency to the washroom. Feeling unwell, sweating, shaking of the hand. These signs and symptoms, if you feel it, please come to us. Why I said this? Because it's one of the tasks. If you go back to the explain the disease counsel about explain the disease. This is the explanation of the disease. Okay, genetic testing already done, but the disease. How about the main 2A? How the patient will present again? So you have to say these details. But for the replacement, it wasn't there, so don't go through it. Do we give IV fluid in end of life care? Yes, of course, Dr. Rabia. We give only IV fluid. We don't give other than IV fluid. IV fluid
But
plus
some,
painkiller.
sometimes it's not a rule to give IV fluids, because we make the patient that he will take IV fluids and he will be overloaded. So the IV fluids only
Mm.
give it with special precaution. If you find the patient is approaching the end of life, we're stopping even the IV fluids. We're giving him only sip of water.
No sip of water in the end of life care, unless the patient is awake. But the patient never ever the patient in the of life care he is awake. Okay, let's go back to the eye fluid and overload.
For
And
end of life care, so the end of life care, the patient may. I saw one patient, and she was with us. She was having cancer, which is metastatic, and she said, "No, I don't want to have medication. I want to have end of life." So
okay, good.
we transfer her to the side room. Her
Yeah,
family was with her for 3 or 2 days, and the palliative team was seeing her also for end of life. So they give her the analgesic, they do suction for secretion, give her, if she has breathing high, they will give her medication and morphine to decrease her breathing. And important, they do mouth care by putting some sponge in the mouth and clean the mouth. And also they give the patient sip of water, or the parent sitting next to the patient with sponge and put some water on their lips, only sips of water. So
you said he's responding, right?
no, and then he died after 3 or 4 days. This is end of life. It was end of life.
Yes, but once he's comatose, you can't feed him or even give him sip of
Oh,
water.
he sip of water for when he start to be drowsy, only sip of water for to make not his mouth dry.
Okay, no, this is not for swallowing. Sip of water to swallow different than making
No,
the
I'm
mouth.
sip of water is not give him too much water. Only by sponge with water
Okay,
inside the mouth, small drops, and finish.
okay, but it's not for swallowing.
No, not for no, he swallowed
Yes.
drop
No, I don't think he will swallow it. He's in coma. Maybe in the first days he's awake, some response, but
because he started to be drowsy, and then he'll enter in the coma. Okay, so
yeah,
you it's we can give, but I think the IV fluids, they are have precaution in the IV fluids, because you will give IV fluid useless. You might put the patient in overload, and the kidney will start not to function.
الموظفين.
So the IV fluid also is given with precaution, not frequently.
I am not saying in cardiac patient or heart failure patient you should give the patient 100 ml per hour IV fluid. So according to the patient condition, you are not giving IV fluid by high dose for no reason. Okay. So let's make some exceptions. So in the cardiac patient, yes, I will reduce the amount of IV fluid, but I will stop IV fluid. So how he will get the calories? What the benefit of IV fluid? Patient needs some calories in every day. Why you are eating? To get the calories. So any patient also he wants to have his calories. How he will get it if he's not taking by mouth?
And why you will give him calories? He will keep him for
The
that.
person, there's no role of calories in the end of life care, okay? End
One
of life care is going to die within seconds or minutes or hours.
one
So
or
no
two.
area of calories at all. You just have to keep him NPO. I am not sure even sips of
No,
water
no, no,
just to
no,
keep
no.
him right.
No, Dr. Rabia, not MPO. I did it in the scenario. Yes, yeah, sorry, MPO, but
No,
IV fluid, you will not give. You will give IV fluid. You
Okay,
can.
we'll confirm this because according to my knowledge, there is no IV
Mm.
fluids in end of life care. You don't put even IV cannula. You just give PRN morphine or some low dose benzodiazepines to
How
make
you
him
will
to
give
get
it
more
without
sleepy.
cannula? How you will give it
You cannot,
without
you
cannula?
can give it directly in the IV. There's no put cannula. They are specialized nurses. They can give morphine directly. And even small dose of benzodiazepine, only antiemetic IV if he has some type of nausea
No.
and vomit. You have to make him relaxed, okay? He is going now.
Yes, we'll not give him subcutaneous injection, or there is also a syringe, palliative syringe contains this medication that can pump it.
Pump
So
it where? Subcutaneous.
yes, subcutaneous.
So there is
No,
cannula.
no can.
How the pump will pump the morphine?
It's I know it's subcutaneous. I don't know
So the subcutaneous mean needles.
under the skin. Yes,
Yeah, subcutaneous cannula. Yes, okay.
yes, yes. Not the intravenous can, not the cannula that we are giving. But the end of life care, it's not minute, or it can be days or 1 week. It could be like this. So his end of life care, you are not doing the vitals for him. You stop all the medication. You keep the family with him. If he asks about food and he's conscious about luxury food, we call it luxury. He want chocolate. He want any luxury food, he can have it because he's still conscious. He's not in coma. Some of them have ask about the end of life and they are fully conscious, but they have advanced cancer, so they will die quickly.
Yes, and
But
whenever they
uh,
are comatose, you can't feed him or feed them.
if comatose, but if not comatose, they can have
Of course, if not comatose, he can give. You can give him whatever he wish. Yes,
yes,
of course, but not of all of them are conscious.
yes. If
Okay.
no, all
And
no, because they will have aspiration.
yes, exactly. This is another issue. He might aspirate if you give him GT feeding in a large amount, and he's dying, by the way, as you said. Also, for Dr. Rabia, the IV fluid, it should be there. What I know, this is the end of life care. Only IV fluid plus some painkiller. Okay, I said it in the exam, and no one comment on the IV fluid. They commented only on the NGT feeding by negative comment. But for IV fluid, I kept saying no. We will continue IV fluid and painkiller, and no one comment on these at all. So I guess IV fluid is correct. And you can ask also other mentors or other tutors. Okay, let's go to the other scenario because we spent long here. Mr. Donald Murphy, 74 years. You are about to see Mr. Murphy in the clinic. He had a right apical bronchial carcinoma, pancreas tumor, diagnosed 8 months ago. He had radiotherapy for a bony metastasis in the right clavicle. His pain, however, has been worse over the last 4 weeks, and he was started on morphine sulfate tablet and is presently on 30% BID. In addition to the Voltarol, I guess this is Voltaren, he was already taking. However, the hospital nurse specialist tells you before the consultation that she believes he is refusing to take his analgesia, and as a result, he is suffering greatly from the pain. Mr. Murphy is fully aware that he has terminal illness. Your task, analyze the patient's pain control and explore the possible reason for the non-compliance. Okay, give me 2 minutes.
Okay.
I'll just prepare. Okay, ready, Dr. Sarah? Let's start.
Yes.
And set the timer. Okay. Hello there. I am Dr. Mukhtar, the doctor in the ward today. You must be Mr. Donald Murphy.
Yes, doctor, I am.
You are 74 years.
Yes.
Yeah. How do you feel now, Mr. Donald?
I'm feeling good, doctor. What I will do?
Okay. And do you need anyone to attend this meeting with us?
No, I'm living alone.
So are you okay?
Yes.
Okay. We are here to discuss about your health issue. Is that okay for you?
Okay.
Yeah. Can I know what you know so far about your condition?
Yes, doctor. I know that I was having a right-sided cancer in my lung, and this has been diagnosed 8 months ago. At that time, also they noticed that I have a spread of this cancer in my right collarbone, and they gave me some radiotherapy, which helped me and caused for me some relief. However, over the last 4 weeks, I think that the pain also started to become again in the same area, and I'm really struggling with this pain.
Okay, I am appreciating your sharing this with me, and I'm so sorry about what you went through. And I'm so sorry about your diagnosis, Mr. Donald. Be sure that we are here to help you and support you. And anytime you have any concern, you can stop me and I will address all your concerns. Is that
Yes.
okay?
Yes.
So you have any idea about what's ongoing?
Yes, I know that I'm on Paddy, and this cancer is a terminal, and I'm on my last day of on my last day of life. So I'm aware about all of this.
Yeah, I'm sorry about what I'm hearing and I'm sorry about your feeling, Mr. Donald. So may I know why you are not accepting our painkillers? This is what I understood from my nurse.
Yes, I don't know why you are keeping try to force me to take this medication. I don't know. I think it won't affect anything. So why you are trying to force me and ask about me all the time to have this medication?
Yes, I appreciate your concern, Mr. Donald. We are keeping all our patients on this painkiller to be sure that they are not feeling any pain. That's why we are giving you all these painkillers in order to keep you pain-free totally. I know it's difficult to be free totally. However, we are doing our best to help you on these feelings. I know it's so hard to feel this pain all the day.
Yes, okay. Sometimes the pain gets worse, but I don't want to take this morphine tablet.
Yeah, I appreciate your concern. May I know why you don't want this morphine tablet?
There's many. I don't know. I'm not feeling comfortable to take them because also it will it will make me feel more drowsy. I read about it. It causes constipation, and since I have this cancer, I'm not good in eating, and it's not helping my bowel at all. And also, I don't want to be addicted for it.
Yeah, I appreciate your concern. And be sure that we are giving this medication the best interest for your condition. However, the morphine, yes, one of the medication with some risk of addiction, but be sure that we are not exceeding the level or the dose that can cause the addiction. And we want to be sure that you are not feeling any pain, Mr. Donald. How do you feel about that?
Um, so you are sure that it won't cause for me addiction? She's giving me high dose.
Yeah, I appreciate your concern. Be sure that the addiction for any drug will be on long time and for long period of time. In your condition, we are trying to give you the best interest for your condition. And this time, the morphine will be at the dose and the full dose, which is not leading to the addiction. Did you get that?
Okay. The other things, I don't want to die while I'm sleeping. It can cause for me confusion, and I might die while I'm sleeping. I don't want to have this happen to me.
Okay, so you want to be not aware about anything in the surrounding. You mean that?
No, I don't want to. I want to be aware. I don't want
Okay.
while sleeping.
Yeah, so we will call our pain management team and the pain doctor to be sure that the dose will not cause this confusion you are afraid of. And regarding the hard stool or the constipation you had earlier, we can give you some medication that can make your stools lose little bit and it help you for your bowel. How do you feel about that?
Okay.
Okay, any other reason I should be aware of?
No, this is my things, because I think I'm feeling pain, and this pain make me wake at night. But I'm thinking that I'm able to tolerate this pain without having this tablet, because I read a lot of side effect of it, and I don't want to have it. That's why.
Okay, if you feel that, we can also call our pain team to find another solution. Some patients might benefit from the injection under the skin. So this is another alternative solution. If you are not tolerable to the morphine, we can switch you to this medication. However, it will be the decision of the pain management team.
But this also is one of the family of the morphine, right?
Yeah, it's another form and it will be under the skin, so you will not swallow it. So the effect will be much strong and the dose will be lower than the one you are taking per mouth.
Okay, and this one won't cause for me constipation?
Still, the drawbacks of any morphine, it might lead to constipation. However, we mentioned that we give you some of the medication that help your bowel to be passed.
Okay. Okay.
How would that sound for you?
Let me think about it and I will let you know.
Okay. I appreciate your knowledge about what you shared with me, Mr. Donald. And again, we are here to help you and support you and to be sure that you are pain-free and you don't have any complaint in these days, particularly.
Okay.
Okay, you have any other concern?
No.
Okay, can I ask you some questions?
Okay.
Who's coming to visit you?
No, I don't have family. I'm living alone.
Okay, and do you need any other kind of support?
I'm okay. No.
Okay, so you mean no one dependent on you
No.
at all?
I'm having some support from the government.
Okay, and you have any wish or did you write any will for any person?
No,
Did you?
I don't have any family.
Yeah, okay. Do you wish something to be happen to you or something you want to do it in I mean now before you lose your awareness?
Yes, no, I want to die at home.
Yeah, I appreciate your wish and we can document this in the file and in order to let you go home, but we have to have someone to give you some care at the last moment of your life. We can call our nurse, specialized nurse for that.
Okay.
Okay, or we can contact the nursery home care. They can provide the nurse to be away, to be beside you.
Okay. Sounds good.
Okay, any other concern?
No, thank you.
How many minutes remains?
Oh, less than 1 minute. Sorry.
Okay,
Okay.
so I can also give you some news to read about or to be aware about the condition, some leaflet brochures and website, some YouTube videos, you can know about the medication and the side effect. And let us know if you need any help, please.
Okay, I'll let you know. Thank you, doctor.
Yeah, and before you leaving home, we can give you the contact number of our hospital, and we will be beside you. Don't worry.
Thank you. That's really helpful. Thank you.
Okay, thank you, Mr. Donald. Time
Time.
is up. Yeah.
Yeah.
Can you
Good.
please give me the comment?
You did it very well. Okay. The only thing I think that you can say, you ask about his mood, so we can.
Yes, I forget this mode. Yes.
Yes, because he might be depressed also. So he give you some support, and also we can do a group support to help you,
Yes.
because he's living alone. So we can do some group support. Some people have the same condition, so you can help you to overcome. And we are not alone in this tough journey. We are here with you. So you can give some, but you give already some good support, and you supported him all the conversation. The only things regarding the opiate, when he said psychological dependence, so you can say that addiction doesn't occur when it's used for terminal pain. When the patient is having severe pain, usually addiction will not happen.
Yeah.
So addiction, that's why they are giving it and give more dose and these things, because in the patient, if he's in severe pain, he won't be addicted to opioid.
Yes.
This is the only thing that you can say it. Otherwise, you address my concern regarding the constipation, and then you discuss with the palliative team to give you other medication, to not to make to make me confused. But you address all the question. Only you need to ask about the mood, and because this patient is living alone, you did it well. But telling him, when I told you I want to die at home, so we can help you, the package of care can take care of you. They called fast track. When patient wish to go home, they called a fast track pathway. Fast track, it means that to make the home quickly suitable for him, and he can die at home. But
Mhm.
to see this, but we will do that. So we will try to make it quickly, that you be able to have your treatment at home, and we'll arrange the caring team, the palliative team, or the caring team for you. Because this patient in this scenario, he's living alone, he doesn't have a family, but he wished to die at home, so we can help him. And you did it good, very, very good, that you ask about do you have any wishes. So some of them can say, I want to die in home, caring. And some of them say, I want to die at home. So you did it well by asking him. This is my comment. I don't have too much comments, only these things, but you did it very well.
Thank you, Doctor. Actually, I have comment when you insist about the addiction point. I wanted to say why you are afraid. You are dying after how many hours, and you
I
are
know,
worried
but
about addiction.
this is
You
was
are dying.
I don't.
Okay.
This was the scenario like this, I don't.
Yeah, I know, I know.
That's why.
But don't do that. I mean, this is like a horrible mistake. If you do it in the exam, I mean, I guess they will fail you. So
Yes,
don't say to him, no, that why, uncle, you are dying after a couple of days. So
yes,
why you are afraid about something which will not happen ever,
yes,
because you are already in the terminal condition. So it's real, but it's not logic to say it.
yes, yes.
Yes.
Right.
So please don't do it. I'm just saying it and like a joke only.
I know. Yes.
Okay.
Mm.
Thank you, Luxana. Nice scenario as
Okay.
usual. Any any comment or any question from others? I want to make open discussion for any communication, or particularly the communication scenarios for today. Okay, question: is it okay for the candidate to raise an issue or give an advice not mentioned in scenario? Like here, Dr. Bassem advised the patient to switch to other medication not mentioned in scenario. Yes, I agree. They didn't mention to advise the patient about it. Yes, because he insists about the medication and he's worried he doesn't want it. I offer it as option. I agree if not mentioned not to do it, but because he kept asking about the medication and the side effects. So I thought it might be a solution, and I didn't say it will be done. I said there is alternative option, and I will call the pain management team to see if they can do it or not.
I think you can say better. I will ask the palliative team. They can have other option for you,
Yes,
but don't say subcutaneous or more detail about that. So you can say
yes.
make it open like this.
So more or less, I agree for your comment. Yes, really. As I said earlier in the previous scenario, don't do or don't give solution which is not written. I did that, but I said also could be it's as a option or as other solution if you are not tolerable to the morphine by mouth. By the way, some of these patients they will not get benefit from the oral morphine. That's why I thought about subcutaneous. Why? Because they have vomiting, for example, because of some cancers can lead to vomiting. And whenever he took the medication or whenever he take the medication, he will vomit it again. That's why we are switching to the alternative route, which is subcutaneous or IV or whatever. I gave it as an option, but it's not mandatory one. You can say we can find another solution or another alternative option by the pain management team or the pain doctor. He will come to reassess you if they can give another medication which can help you in your condition. But don't miss his concerns. Whenever he had concern related to the medication he's using, for example, in this scenario, he said, I cannot tolerate morphine anymore. Ask why? You have to ask even up to 3 whys. He might say, I had constipation, so you have to answer this constipation and you have to address it. He said, I have, for example, vomiting, so you can say, we can give you some medication, can help you not feeling sick or not throwing up. If he said, I am worried about addiction, so you can reassure him, we are not giving you this medication as the addiction purpose. The other people who's taking for addiction, they are taking it while they don't have pain, as Dr. Sarah said. Or you can say we are not exceeding the limit or the dose that can lead to the addiction. Okay. So in this scenario, he has concern related to the medication. You have to address all of them to get your mark. This is your task in the scenario. Patient refuse or not compliant to this medication or not compliant to the morphine. You have to address it why and why and why till he will be convinced and agreed to take it. Thank you for your comment, Dr. EA. Any other comments? Any question? Please. It's not one-way discussion, it's interactive one. So you can either comment, you can give advice, you can raise a concern, you can ask question, or I will choose
My
myself.
only concern, my only comment, Dr. Basson, is that when we already prescribe for the patient morphine, we usually prescribe already the lactulose or any laxative with it.
Yes.
So it's already complementary. So if it's not prescribed, I have to reassure the patient and prescribe it for him as well, right?
Yes, you're right. And sometimes we are giving up to 3 medication or 4 medication.
Yes, yeah.
Yeah, we are sent by lactulose, sometimes bisacodide, sometimes
Yeah.
docusate.
So
So
if I say that, or shall I say that I also can consult
yes,
the palliative team for you for any other concern, or shall I manage with myself and say
you can give him the solution by yourself, but
okay,
if you feel it's out of your scope, you can refer him.
okay,
But it's
yeah,
okay. You can prescribe this medication by yourself. What the
yes,
need, yeah. So you can do it. But if there's some
mhm,
medication which is not by your prescription, I mean, for example, by psychiatrist or depression, antidepressant, so you can refer him or you can call the patient or the concerned team, which is the psychiatrist, to see him and they can prescribe which is the best interest in his condition. You got it?
okay, yeah, thank you.
Okay, thank you. Thank you, Dr. Minna, for your question and your suggestion. So yes, as Dr. Minna said, you can either assume that we are always giving medication to help in this constipation, But if you feel still you have some hard stool, we can add another medication, or we can up to referring you to the gastro doctor or the gut doctor if the hard stool is there, is still there. But you have to try 4 or maybe 3 medication for the constipation, up to the enema or sometimes suppository. If you reach to the maximum, patient doesn't pass bowel motion and he's still feeling too much constipation, so you have to solve this problem. This is one of his concerns. And I guess they will not go more deep in this details. They will tell you, I have just constipation and you have to address it from one time only. I mean, one solution, not more than this. It will not reach to the gastro because still he is terminal condition, and I guess they will not do for him any endoscopy or lower colonoscopy or whatever. Okay. Thank you, Dr. Minna, for the comment. Any other question or comment? Please feel free to comment or to ask. Any question regarding genetic testing or counseling? Seems,
That's what I want to ask. If we want to say benign is the jargon?
yeah, better say good or bad. The most simple word to say is good or bad. This is what I use.
Okay.
Okay. Don't put yourself in a zone. Is it jargon or not? So ask yourself, is it clear or is it simple? So benign means, yeah, sometimes it could be, but why if what if I say good and bad? Good growth or bad growth? Okay. But cancer is cancer. Cancer is not jargon at all. So if you can say jargon, okay?
Yes. Okay.
I will ask now for a vote. If you want to make the coming communication about any topic, specific topic, any scenario you want to discuss particularly, you want to discuss another genetic counseling scenario. Anyone has suggestion to do, please let us know. Any debate about any scenario in the communication. So all are satisfied.
Yes.
Okay, so I will choose the scenario myself. Maybe I will continue in this category, or we can change. I suggested post-mortem examination. If anyone knows about it. Yes, sure, we have it. We have 2 types of post-mortem. Either post-mortem in the medical purpose or post-mortem as coroner purpose. So we can do it next session. I mean, next communication session. We can do alternatively 1 and 1. I will see who will be the one candidate for that, and we can arrange together. Okay. Thank you, Dr. Ryan, for your suggestion. Organ donation. I guess we did organ donation maybe a couple of days ago. I can share the session of organ donation because it might be 2 weeks or last week. We just did it. I will share the post or the session in the WhatsApp group, Dr. Nisma. Okay. But we did it maybe, yeah, maybe the last week or the week before the last week. Okay. Any other question? Any comment? Any inquiry? If no more questions, we can end the session. Thank you all. Thank you, Dr. Ahmed. Jazakumullah khair. Thank you all for sharing this session with me and for the attendance. See you tomorrow, inshallah, with clinical day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ryan.